it's quite interesting. We have our patient with uterine cancer, which is metastatic, and she is received already first-line therapy for that, which is sort of the known carbotaxol combination. And she's in a place now where her tumor has responded a little bit, but she can't tolerate any more of that therapy for good reason. It, attacks the bone marrow over time and just her fatigue. So she's come off of that. And yet, what we did was to find a clinical trial that she could potentially go on for situations where there is, persistence of the tumor or residual tumor. And so so she certainly fits into that category. And, her doctor has said that, yes, that therapy would be, and that trial would be fantastic for her. On the other hand, there's sort of traditional therapy. And what traditional would look like is, because her tumor is hormone receptor positive, which is estrogen and progesterone, but estrogen is the one that everyone's looking at, ER positive. She would be eligible, and 70% of patients with uterine cancer have estrogen receptor positive cancers. She would be eligible then for what we call standard hormonal blockade. And that is usually, there's a number of different ones. There's aromatase inhibitors. The one that is used, I think, most frequently in uterine cancer is an alternating regimen between tamoxifen and a drug called Megase. And these work in somewhat particular ways to block the hormonal pathway. So we had been asked to compare the side effects of what she might get on the trial versus what is sort of billed as kind of easy sort of hormonal blockade therapy. And in all rightfulness, we've had a patient that we pulled this out for whose doctor had not offered that, and that patient did really well for years on that therapy. So I thought it was interesting that, as I started to take a look, mostly to find out the side effects, something else popped up. And this is where, this is so exciting about what we do, because, we sit here sort of both as a predictor of the future, as well as someone who does, a group that does deep research into what we find. And what we know is that hormonal blockade is used somewhere else. It's used in breast cancer, and we're for patients who have ER positive, cancers. And what we also know is that about 10 years ago or so, a new drug class came along. It's called CDK4/6 inhibitors. There are 3 of those. Palbociclib was the original ribociclib, and now there's a third, which is abemaciclib. And abemaciclib is nice because it crosses the blood-brain barrier. The others don't, so I tend to prefer that one. However, we know that when paired with the estrogen blockade, it works really well in breast cancer patients, right? And again, the hormonal pathway that is, becoming dependent upon the hormone axis in breast cancer is the same one that's used in uterine cancer. The effects of estrogen blockade are present in breast cancer and the same in uterine cancer. So one would then ask the question, well, why wouldn't you use a CDK4/6 inhibitor in uterine cancer just like you do in breast cancer? Because it works better. And so yesterday, as I was sort of checking this out, now I'm going to share my screen here. Actually, hold on just one second. First. So yesterday, as we were looking for side effects, indeed, I found this article. This article is from 2004, and this is the original article that really kind of staked the claim that hormonal blockade, specifically this Megase and tamoxifen alternating in endometrial, that's uterine cancer, works. And we can look at the side effects, and we will. But what caught my eye was the question of how well does it work? And before I zoom down to the picture here, if we see in the abstract, they give us some clues. And it says that, first of all, there was some responses, and then, that the responses were actually pretty decent. So the overall response was about 27%. And if you did respond, then the duration was quite long, like 20 months. Again, something like what we had. But then they go on to say something very interesting, which is women less than 60 years old, and our patient is older than 60, has a better response than those who are older. And the rates are pretty dramatic, 44 versus 20%. Now, they don't say how well the folks do, except that overall, we know that really that combined responders and non-responders, the average median progression-free survival, so how long was the tumor controlled on average? About 2.5 months, 2.7 months, which is not very exciting. And so one would imagine that really you've got these responders here, which are going for a very long time, and then everyone else that basically hardly responds at all. So I think, from my perspective, that really is two populations, and it would behoove us to try to figure out, is there a genetic component behind that? Is there something in the tumor that's telling us that this patient's going to fit into one versus the other? It may be age, but my guess is that age is because of some other component that is in the tumor of young people. And that's what really is determining the difference here. Regardless of all that, you could see here the graphs, and this is the one that shows disease control, which is the one I like to focus on. And you can see that half the patients come off at around 2 months or 2.5 months. And so that's how they get those numbers. You do see this long tail, and these are all the younger people who got it, women who got this, and that, had responded, the 40%, and then, lasted for quite some time. And so, so that was interesting. But then we get back to the question of, well, what if we were to add a CDK4/6 inhibitor in there? Because again, it works in breast cancer. Why wouldn't it work here? Up until yesterday, that's always been a theory in my head, right? And I would predict that because it works in breast, we should try to do it in uterine. But most doctors would say, well, there's no proof. We can't do that. The insurance won't approve it. There's no proof. Well, yesterday, and now I'm going to stop my screen sharing. I want to show you this article. Here we go. And so this is from January of 2023. It's actually so new that I don't think I could get the publication yet, but we will. And this is a study of letrozole. That's one of those aromatase inhibitors that's used as part of the estrogen blockade, and abemaciclib, which I mentioned is that CDK4/6 inhibitor in ER-positive recurrent endometrial cancer. And again, these patients are going to be worse than our patients in the sense that they are progressing after first line. Our patient is sort of in that stable disease. So if we look at it, we could see that I'm going to zoom in on the age group. They tested 30 patients. Now, half of them had already had prior hormonal therapy, which is interesting. I saw somewhere here the age, that there was a decent proportion of them over 60. I think they used a different number, but in any case, what they saw was a similar response rate of 30%. But what I thought was really interesting was the median PFS, that average duration of control, jumped from 2.5 months to 9 months, right? And to me, that's enough. That is sort of the documentation that I suspected we would find, but now have it right in front of us. And no, it's not a huge trial. They are actually digging into because now, it's not 2004, it's 2023, so we can dig into more of the tumor sequencing, and they have some candidates there that would potentially reveal a prediction for response as opposed to absence of response. And I recall that our patient has a KRAS mutation. So, from my perspective, the question might become not whether or not we do the trial right now, but if we do the hormonal blockade, can we get the CDK4/6 inhibitor with it? And because if we can't, I'd rather again, wait. Now, we don't have to. These patients had it, or half of them had it before, but my preference would be to either wait for time where this now becomes standard of care, or again, apply to the insurance company with this article in hand and say we would like this doublet covered. There are side effects to CDK4/6 inhibitors. It's pretty small, like 20%, I think, have neutropenia. So we'd have to apprise her of that. But from my perspective, this is sort of really exciting, and I wanted to share that with you guys. I'll stop my sharing. Any questions on that situation?
Jason,
Yeah,
I found the article on Northeastern's library. I can send it to you if you want.
perfect. That
Yeah.
would be great.
Mhm.
And I have another one that I'll Slack to you guys later that I'm looking for related to one of other patients. Any other questions?
How long would it usually be for it to become standard of care? Like, is it very long? Like, what's the timeline?
Yeah, it's a great question. It's hard to say because there's sort of two things rolled up into a standard of care. One is the drug approved in that in that cancer type? And I have to guess that for abemaciclib, the answer is no. So if that were the case, then then the company that produces abemaciclib, and I don't know which company that is, would then apply to the FDA for permission to call this standard of care, to have it expand their label. So then when we look up the package insert, it would be there. Like, this is indicated for patients with uterine cancer who have ER positive disease. That process, I believe, takes anywhere between 6 months and a year and a half. Once they file, and it takes probably 6 months to prepare the filing. So, we may be looking at a year at minimum in order to cover that. Groups like NCCN or others can help, because if they declare it in one of their reviews as a standard of care, that may influence the insurance companies to be covering it, because they expect that it will eventually become standard of care. And yet there's also other aspects where, if it's not standard of care, companies, knowing that there's a review period for the FDA, they could open up an expanded access protocol to provide patients with that. And that might take a few months to open, something like 3 months. So the answer is, it's a little bit of all the above. From my perspective, it would be similar to some of our other patients, where initially the insurance company may just say declined because it's going through their algorithm, automated, and that's what it spits out. We then come back to the second part, which is, can we appeal that? And with us or the doctors, where we feed the doctors this article and or letters, or they write up the letters with citing this article, I think they have a pretty good chance of getting it. There's also discounts that the drug companies will give for patients. Those are usually based on financial need. And so, that's something that we could pursue too with them if we can't get through any other way. But, it all starts with the data, and therefore, we'll see. But it is a lengthy process, even when the data is sitting in front of you, to get to call it a standard of care, where no one has to think about it and things are just approved, like this, by the insurance company. That's what's going to be given.
And do you think like a paper like that would be sufficient to like move that process forward? Do you expect that's going to happen?
That's another good question. I mean, there was only 30 patients in this. The FDA could come back and say that they need a full study just based on this, with either hundreds. I don't think they'll last for thousands, but it could easily be hundreds of patients that they would want to have tested this way. This is what I would call a pilot. And actually, it was part of another study that tested multiple different drugs, and that's what came out of it. So I think it's unlikely that this one alone will get it. However, the FDA has actually created an avenue by which they can help, which they can give accelerated approval. It's also called preliminary approval, which is, again, based on the data, we expect that it's going to be better. I mean, 9 months is so far away from 2 months, it's statistically significant, even with low numbers of patients. That being said, so the FDA can give a approval and say, yes, you're officially blessed, and you can add it to your package insert, but you still have to do these other studies sort of on the back end. And that works pretty well. They can do the study in Europe. If the European Union didn't approve it, they could do it. Yep, there's ways of getting those done. And then after that, and that could take a few years, they would then either certify the approval, or they would repeal the approval and take it away. And that has happened in a handful of cases. Actually, there was a few this year, but I'd say Avastin in breast cancer was the most famous of it, where it got the initial approval, and then years later they actually took it away because they didn't feel like the data substantiated the benefit. But that's sort of the how it's done. And again, everyone's trying to do the best for the patients, but they also do want a certain amount of data to be able to certify things.